Hello, good afternoon, everyone. Welcome to the first episode of our series on war injuries that is organized by the ISIG, and that is with the objective to help and spread knowledge and update the knowledge of our colleagues in Ukraine and Eastern Europe. So the objective or the target audience of these series is mainly to colleagues in this terrible situation in Ukraine, to help them face the terrible challenges they have to face every day in uncertainty. So, and of course, to all our colleagues in Eastern Europe, is it Poland or Romania, all the bordering countries that have to deal with situations and injuries they haven't faced possibly in their career. So we're very happy to present a series of seminars on different aspects of the topics of war injuries and trauma in a war situation, starting today. And there will be a series of 5 webinars every Wednesday from 5 p.m. European time to 6:30. Okay, so there will be topics on today. We will talk about triage and organization, setup of a field hospital. There will be topics on ballistic injuries, blast injuries, transfusion management, shock management. So again, I will stop talking because the time is precious. And the important thing is that we would like the session to be as most interactive as possible so that you can get most out of it and really ask as many questions as possible. And our expert will try to answer your questions as good as possible. So I'm happy to pass now the word to Victoria, who will introduce our expert for today.
So yes, Tobias, thank you very, very much. And it is our extreme pleasure to present today Dr. Sam Hutchings, a surgeon commander of the Royal Navy, a colleague of mine at King's College Hospital, who has, I think, unfortunately, Sam, experience with real war situations. And I think we're very privileged to have you here to hear you talk about your experience in the first of all, organization of a hospital or a unit that would accept such patients. And as Tobias was saying, we would like to make this as interactive as possible. So I think, Sam, would you like to start? And Tobias and I will interrupt you, and hopefully we will have questions in the chat. Thank you.
Sure, thanks, Victoria. Thanks, Tobias. And thank you, everybody, for coming to the SICM for the invitation. I have to put the necessary caveat at the beginning of this that I am here in a personal capacity. I am an officer in the Royal Navy, the United Kingdom, but I'm speaking very much here in a personal capacity, and these views are all my own views. So yeah, interestingly, it's quite interesting that the list of topics, Tobias, that you mentioned there. I'd be probably happier to talk about any of the other ones than the one I've actually been given today, because my clinical interest is really in shock management, trauma, and hemorrhage. But it falls to me to chat a little bit about organisational aspects and triage aspects, and that's quite a broad theme, really. So I thought what I'd do to start is I'd just give a little bit of an idea about my personal experience in conflict zones, and then how NATO and how NATO militaries approach combat casualty care and the structures that they try and put into place to put some kind of order on the chaos that happens in a war zone. So just a little bit about me to start with, I guess. I've been in the Navy since 1993. I was in the Navy at medical school, and my first job in the frontline military was actually in a submarine, in a nuclear submarine, and I was the doctor on there for 3 years. So that's a very interesting environment to work in, actually, as a junior doctor. It's a very austere environment with no real communication with the outside world. So it puts you in quite an interesting position in terms of the clinical decision making that you have to do. I then trained as an anaesthetist and later as an intensivist, and now an intensivist with Victoria at King's College Hospital, so a big tertiary centre in London. But my deployed military experience has been in all the usual places that the UK military have been to in the last 20 years. So I served in Iraq and Afghanistan. and latterly in Sierra Leone in 2014-15 during the West African Ebola situation. So that's a bit about me and my background and where I've come from. So I'm just going to stick a slide up. So if we can share this one, hopefully what you can see on the screen here, this is kind of a standard sort of NATO doctrine slide. So don't worry too much about the detail, but it just gives you a bit of an idea about how the military approaches combat casualty care in the broader sense from an organizational point of view. So what you can see is this is a patient, a typical sort of patient who's injured in a battlefield situation, at point of injury, undergoes a series of sort of doctrinal steps, and each of those steps NATO lays down timings for these that we aspire to meet, and we cannot always meet, but the aspiration is we try and meet these minimum timings. So from the point of wounding, within 10 minutes, the soldier is the aspiration is that the soldier will have what's called care under fire. So this isn't delivered by, usually not delivered by a medic of any description. This is normally sort of buddy care. And this kind of thing is really would be application of sort of combat application tourniquets, very basic, pressure dressings and that kind of thing. So that's sort of 10-minute doctrine to meet that. And then there's this concept of field care. And now field care is pretty much anything that happens before what you and I would recognize as anything like a hospital, even in a very sort of primitive sense. So field care is usually doctrinally about the first hour, and then within that hour, a casualty should have presented to a casualty clearing station. Now, this is the first time they will actually encounter somebody who's usually a doctor, but they won't be a specialist. So they'll normally be quite a junior doctor. And the kind of levels of care that you're looking at giving to a casualty in a casualty clearing station is pretty basic. So it'll probably be oxygen, it'll probably be intravenous or intraosseous access, it'll probably be fluid, but it might not be blood, depending on the setup. And the achievement is that you would try and do that within an hour. Now, within 2 hours, NATO doctrine is that you'll try and get a patient to deployed hospital care. So this now starts looking a little bit more like something that you and I, Victoria, would be maybe used to working in, although a bit more primitive. So this is what we call Role 2, or deployed hospital care forward. You can see it's pretty primitive stuff. It's basically just a kind of, it's not a mattress, it's just a sort of cot stretcher bed. There is a monitor, there are some syringe drivers, and there is a ventilator. This particular ventilator is a pretty ancient thing that its main selling point was that you could drop it out the back of an aircraft and it would bounce, but it's not terribly good at ventilating patients with complex or even any kind of lung injury. But this is what you would get at a sort of forward hospital care facility. It's pretty portable. You can see it's in a tent, but it is exposed. Environmental controls a little bit difficult. Often the places I went to fight in were very hot, usually, and trying to keep places like this cool is very problematic. One interesting thing you can see on the screen there, you'll see there's an oxygen cylinder line sort of the bottom, but the funny sort of beigey coloured box thing that you can see in the background, that's an oxygen concentrator. And that brings us into one of the interesting points about logistics and consumables that are often problematic in austere settings. You rarely have enough oxygen, certainly at far forward zones, but oxygen concentrators are pretty good. And we used to be able to chain them together. So you put 3 of these together, you could usually get about sort of 80%, which was enough for most casualties. So that's a sort of forward deployed hospital care. And if we just move on, this is similar structure. So you're still in a tent, but you can see you've now got something that is a proper hospital bed. And that makes an enormous difference if you're holding casualties for any length of time, because if you leave unconscious ventilated casualties on the former setup, then they're rapidly going to run into big problems of pressure areas. But this is a sort of intensive care. These are all intensive care units within these hospital facilities. So this is the intensive care unit at what NATO calls Role 3, or what sometimes we also call deployed hospital care rear. You can still see their oxygen concentrator there, you've got the same monitor, you've got more syringe drivers, you've got a better ventilator, and that's the main difference. You've got more space and you've got a better bed. And you've also got, in this setup, different staffing. So this setup would normally, is the first stage where you probably would encounter a dedicated intensivist. Most of our forward medical deployed hospital care, critical care, is still provided by anaesthetic specialists rather than dedicated intensive care specialists. And just for the sake of completeness, now this is no longer really austere. This is the intensive care unit in the field hospital in Camp Bastion, Afghanistan. And this is hard standing. So it's basically not a tent. It's fully air conditioned, it's environmentally controlled. And to all intents and purposes, this was like working in a standard civilian ITU at home. There were a few differences in the capability that you could provide. So we didn't have renal replacement capability most of the time. We could bring it in occasionally when we needed it. But that was the main difference. We didn't have TPN either. But most other things we had. Some monitoring aspects were missing. But in terms of the sort of care that patients got, staffing ratios and stuff, this was actually a really good ITU to work in. So we can probably stop sharing those slides now, because that sort of summarises the main doctrinal bit of how the military approach combat casualty care in the broader sense. That's probably a good time for me to stop talking.
Sam, that was great. Tobias, shall I start with the questioning? And by all means, please put things in the chat. This is what all this is for. So this was interesting for people, I think, definitely like me, that have no experience in wartime. But you were talking about soldiers, and you were talking about what we are experiencing now is less soldiers and maybe more civilians, and maybe not the initial very basic type of tents, for lack of a better word, that you were talking about, but maybe in the areas that are now war areas, people do have hospitals. They're just not as equipped and as streamlined as they are in NATO, for example. So I was wondering whether you can give us some pointers around, if you have a hospital, whether that is a district smaller hospital or even a bigger hospital, are there ways to reconfigure that hospital to make it more, I don't know, efficient, for lack of a better word?
So that's a very interesting question, and it brings us quite nicely onto a point, I guess, that all we do in these field hospitals generally is one thing. You know, they're a one-trick pony, as we say. They you know, the reason why the field hospital in Camp Bastion, Afghanistan, was so good at what it did and why the outcomes were so good is because we weren't trying to do anything else, and we didn't have competing priorities. We were purely set up to deal with trauma, and often one specific type of trauma. So I guess the answer to your question is to try, and if you are seeing that you're getting, you know, you've got a predominance of different phases of conflict, haven't you, of different types of things. So if you're in what we call a sort of high intensity kinetic environment, where you've got lots of ballistic injury, lots of blast injury, then you need to try and streamline your resuscitation service so that your emergency department, your imaging setup, your operating setup, and the three things that need to interlink very quickly in a trauma setup like that are working pretty closely together. But unfortunately, warfare's not really that clean, and in a situation that you'd find yourself in a situation where your country's been invaded, you have large amounts of displaced people, and you're actually trying to provide standard medical care as well as trauma care, it becomes more difficult. And I don't think there's any easy answer to that. You can describe how you set up a very effective, dedicated, bespoke trauma service, but the disadvantages of doing that is you basically knock out the other stuff that you're trying to provide. And it's an important point to say that, you know, although I'm here as an expert being in the military, We, were very privileged, really, that we only had this one job to do. We were very well resourced. We had a very effective trauma system parachuted into the middle of a conflict zone. Whereas what's going on, I guess, in Ukraine at the moment is not that at all. There's a conflict which is ripping apart the infrastructure, and whatever you try and put in place has to affect that.
That is one of the questions I wanted to ask you, referring to the 3-tier level of care. So if we would like to refer this or to transpose this maybe to the situation in Ukraine, is that one possibility could be to set up something that is equivalent to combustion in a safe zone? Do you think that could be a strategy, is to a very like a 3-level care level in the hot zone and bring patients out of the hot zone and try to set up in less affected areas, protected and high intensity care levels?
Yeah, for sure. That is exactly what the military setup tries to do. So the further away you get from the sort of sharp, pointy end and the fighting, the more infrastructure you're able to have. The thing that mitigates against that is you need a pretty effective clinical transport system. And certainly in Afghanistan, not so much in Iraq early on, but certainly in Afghanistan, we had a very, very good and effective system of moving critically injured patients around the battle space. And unless you've got that, it's very difficult to sort of meet those timelines. You can't really meet those sort of 2-hour timelines to damage control surgery unless you've got a way of moving patients around. I mean, we did it in Afghanistan. It was all by air. There was hardly any road movement because of the problems with improvised explosive device attacks. So all the patients and the distances were pretty large. But certainly to have this whole NATO 3-tier system role system 1, 2, 3, it's predicated on actually having stuff that can move patients around. And also you rapidly run into problems at your higher tier levels, that you get overwhelmed, you have too many patients, and you then can't admit more patients because your hospital is full. So you also have to have a mechanism of strategic evacuation, which we could do in the conflict we were fighting, which is more difficult when your country is overwhelmed, to move patients from the area where the combat is to another area in another part of the country, say. So you decompress your system continuously. And we would have, as soon as a casualty arrived in the hospital in Afghanistan, we would be signaling the UK, and the team that would come to collect them and take them home would be in the air, often by the time they were out the operating theatre and in the intensive care unit. So that's really important, that kind of decompression, so you don't overload your service.
There is a question in the chat. The participants are interested about exactly what you mentioned about the transport system and challenges that you could face to set up transport systems, or what kind of resources you would require to have transport between these 3 levels of care.
So you can use anything. It's not so much the vehicle, it's the team that goes with it. And it really depends on what you've got. And it really depends on what kind of experience and infrastructure you have. We evolved a lot over the course of the Iraq and Afghanistan campaign from 2003 to 2014. At the beginning of the Iraq campaign, when we had mostly, as far as the UK was, and my experience of it, we were involved in the south of Iraq, and most of our operations were in Basra, and we had a hospital that was right outside the city, and most of the casualties were taken within the city initially. So it's a very short transit time, and the casualties were usually moved, certainly early in that campaign, in fact almost all of that campaign, they were moved by a non-clinician response team. So you had paramedics or sort of paramedic equivalent moving patients. And the emphasis was really on speed rather than treatment. So if you, in the kind of pre-hospital care terminology, it's kind of scoop and run. Whereas in Afghanistan, there was differences between the nationalities in Afghanistan, but the UK approach was very much take the hospital and take the critical care element, particularly to the patient. And the clinicians that operated on our medical emergency response teams could do pretty much, they could do most stuff. They had a fair bit of blood and products with them. They could do thoracotomy. They could, they could do lots of life-saving interventions en route to hospital. So it depends on the context of how long your transfer times are. In Afghanistan, our transfer times were very long, often from where the fighting was to the Royal Free Hospital. The only option was to go by air, and it was such a long transfer time that you needed to actually send the team to the patients. But if you've got a very short, if you're actually taking casualties in the middle of an urban conflict zone and your hospital's in that urban conflict zone, then sorry, that's my dog in the background moaning for anybody who wants to know. Sorry about that. So if you're embedded in a city and you're taking casualties in a city, then and you've got short transfer, you're probably better off doing a kind of scoop and run approach rather than investing in a very physician-heavy team.
So, Sam, thank you. I think there's a follow-up question. I think you might have just answered it, but I think if you have the ability to transport a wounded patient in 1 or 2 hours' time to the hospital, you don't need intermittent hospitals, field or forward or field rear hospitals, just efficient transport systems. Is that correct? Yeah,
and there's a phrase that we used to use to describe exactly that situation, which is a clinical speed bump. And you often don't want to have this role 2 if you've got a role 3, which is more capable. And the difference in the principal difference in a role 2 and a role 3 in NATO is, I think, is imaging and intensive care. So role 2 doesn't have a CT scanner, and I can't remember the last time I had to do trauma without a CT scanner. You can do it, but it feels a bit uncomfortable because the first thing you do with a major trauma patient is put them through a CT scanner and scan everything. Broadly speaking, a lot of in Afghanistan there was. Patients often stopped off at a role 2 for damage control surgery when they maybe could have gone on to a role 3. And there were national differences between the countries that were operating there. But really the whole point of a role 2 is if you've got a patient who is essentially got what we call sort of P1 injuries. They've got a life-threatening injury, which is often hemorrhage. And you need a surgical team to control the hemorrhage, and that's the thing that you need to do to stop the patient dying. And in that situation, they're valuable, but often if you're just going there because it's there, then it can slow things down unnecessarily and stop you getting to the definitive point of care.
Okay, what kind of competence level do you think is required for each level of care, or for each for a level 1, level 2, level 3 is obvious is a hospital's care level, but what kind of staffing would you consider for level 1 or level 2?
Well, typically at a tier 1, you would have a doctor, but that doctor would be very junior and would be kind of like what we call a regimental medical officer in the army. And so they may have only done a couple of years of training. They would have done sort of basic military training and a bit of basic medical training, and they can do resuscitation in the broader sense, but they obviously can't do damage control surgery. They're not going to be able to stop bleeding. They've got no advanced techniques for that. So it's really about putting oxygen on, getting access, intravenous access. And providing some degree of IV fluid, maybe blood, but maybe just crystalloid in that environment. So role 2 is the whole shooting match, really. You have a full surgical team there. I say a full surgical team. You have a general surgeon and an orthopedic surgeon in the UK model, and you usually in the UK model have 2 anaesthetists, but you wouldn't normally have an intensivist. You would normally just have an anaesthetist in that setting. Role 3, you then start adding on all the other layers as well. That's when, and the other big difference within role 3 is the surgical specialties that you have. So you would have potentially neurosurgery, which you wouldn't have far forward, potentially thoracic surgery for some nationalities, and then things like maxillofacial surgery, ophthalmology, and things like that would be provided at various aspects of role 3.
So, Sam, there has been a question comment in the chat, which I think it's really accurate. I'm not sure if you will be able to, or this webinar will be able to address it. So what happens, let's not make it for Burma, or just what happens if you're describing situations where there is some provision, there is an oxygen concentrator, for example, or there is something. But what about when the majority of medical infrastructure is no longer functional? And I do know, Tobias, I do expect that in the next webinars, when we talk more about practical management, I think we'll go from the very basic to more, elaborate types of management. But I think what happens if the majority of the medical infrastructure has been taken out? I mean, to me, logically, that means that most of the things that you could do, you just can't do, and you just accept that. Is that what happens?
I mean, I've never operated under those constraints. You are then, I mean, you're then coming into the kind of triage ethical discussion that I think we might touch on a bit when we talk about triage. And that's, you've just got to do what you can for the most people that you can. And that may involve making difficult decisions. I mean, in any austere environment, you end up making difficult decisions. Even in a fully swept up military deployment, you end up making difficult decisions all the time, far more than you ever do in a civilian setting. Because although you have resource, you don't have anywhere near the resource that you would do in your day job, in your civilian day job. You have a very finite bed pool. I mean, we were amazingly lucky in Afghanistan. We had a 16-bedded intensive care unit. But in Iraq, I had 3 intensive care beds, and when they're gone, they're gone. And unless you can get the patients out, you have no more capacity, and that's quite challenging. And the other thing that it is not really answering your question, but it answers it in the best way I can using my experience, is that you have to consider the context of what you're doing against the longer term, against what you can provide in terms of the outcome for those patients, because you can throw everything at them and do all this amazing damage control surgery and resuscitation and take the most horrendous injuries and make them survive. But the majority of the patients that we treat on deployed military operations are not UK or US or NATO soldiers. They are local civilians, and at the end of the day, they have to return to the local healthcare infrastructure, whatever that is. So you have to balance the ethics, I guess, of what you're doing early on with what outcome you can provide late. And that sort of answers your question, because there's no point embarking on stuff if that you don't have the wider support in the country, the wider infrastructure in the country to support the medical care you're providing. And it leads to some very ethically challenging decision making.
Which you refer is what happens to the patient once he is ready to get out of the ICU, for example.
Yeah. Which
might be a challenge that the colleagues in Ukraine face, because there might be no more rehab centers or the transport to the rehab center or to any later care facility might be inexistent.
Yeah, or there may just be no other medical facilities
left
of any description. There was I had a situation in Iraq where we had this patient actually who if we do come up to discussing an individual case, is a case that I've got, here who we did an amazing job on, I think, in terms of his injury severity and the physiological derangement that he had when he presented. And we got him through the whole of his, critical care run, got him extubated, but he still had a massive burden of injury. And that would have been very significant in a completely swept up, Western healthcare system. And then you go, well, what do we do now? And it's very challenging. You want to keep these patients forever because you've invested so much in them, and you know that once they leave your system, things are not going to go terribly well for them often. But it's very challenging. There's no easy answer to it either.
So, Tobias, do you want to? There are a couple or more questions in the chat. I think I'm going to try to understand this correctly. It says normally you should not have to hide the hospitals, but is it necessary in this type of war?
To hide them.
Hide hospitals. I don't know, like a camouflage, or they're not obviously targets, I guess.
Yeah, I wouldn't want to get into the politics of that too much. I mean, there are Geneva Convention rules that govern attacks on civilian targets, and specifically on targets that have, protective markings, such as red crosses and red crescents. Various state and non-state players abide or don't abide by those rules. So that's a decision I think that you can only make on the ground. I mean, all NATO field hospitals generally are flagged up as hospitals, whether they depending on where they are. Often, if they're within an established NATO UK military base, they won't have a massive, great big, Red Cross outside the front door, but they often will have a flag with a Red Cross on. But sometimes, very sadly, a marking infrastructure up in that way makes it a target in some people's minds.
Okay, thank you, Sam. There's another question on triage. You touched on triage, and there's a question: is how would the most frequent causes of preventable death, such as hemorrhage, compressive pneumothorax, airway obstruction, how would they affect you from a civilian approach, let's say ATLS standard? How would they affect your triage decisions in a combat zone?
Fine. Let me stick a slide up on that, if we can just share the slides. And I'll just go through, that's a very good segue into talking about triage more broadly. So I guess the thing about triage is that I have to say I've not done much of it, because you only need to really do triage when your infrastructure is overwhelmed, because it's basically a way of prioritizing the casualties that you need to treat immediately to stop them dying, versus those that can wait. And so the whole triage systems that we have in the military and in civilian settings, they're broadly similar, are designed to treat mass casualty situations. And they're designed mostly, the example that's up on the screen here is an example of a military triage sieve. Now, this isn't designed to be used by doctors. It's certainly not designed to be used by specialists. It can be used by junior doctors. But it's designed to be used right at the point of injury. And it tries to tee out patients who can survive from those who can't survive, and those that may survive a little longer if you leave them. So this is a pretty primitive tool, though. If you look at what it's telling you to do, it's basically the classic one is, are you walking? Yes. If you're walking, you get shuffled off into a sort of reception centre where you're dealt with later. It's essentially sort of minor injuries pool of people. Then the key step in most of these triage tools is the respiratory rate, and that's problematic because it's quite difficult to measure objectively under most circumstances. But you can see here that basically, if you're in a mass casualty situation and you're not breathing and somebody tries to open your airway, you're effectively, and you're under enemy fire, that's it. There's nothing really else you can do. If you're in a single casualty situation and there's a facility to treat, then you're into a kind of basic life support and maybe advanced life support later when other people arrive situation. The military changed an enormous amount in the early phases of the Iraq and Afghan conflicts. It changed the way its treatment paradigms worked in terms of ABC to putting CABC and putting control of catastrophic hemorrhage before airway. And I think that's broadly, very well established now. But it brings us to the point that most people, and your question alluded to it, the majority of preventable rather than non-preventable death, the majority of preventable traumatic death is from catastrophic hemorrhage that's uncontrollable. So the use of combat application tourniquets early on in this kind of triage sim is very important. Then you get into a stage of once you've controlled that, looking at the respiratory rate, as I said, and then there's various arguments about where you set these parameters for respiratory rates, particularly the upper level, and there's modifications to this that would put that high respiratory rate level at 24 rather than 30. But all of these patients who've got a rapid respiratory rate are going to go into a T1 category, which is the highest category, which is immediate treatment required. And then the difference between a T1 and a T2 in this sieve goes on your pulse and your level of consciousness. Now, that's a triage sieve. This is the other military thing that's used in the UK military. This is a triage sort. This is a little bit more sophisticated. So this is designed to be used by, rather than to be used by like combat medics, this would be used by usually sort of junior doctor level regimental medical officers. So this scores Glasgow Coma Score respiratory rate and systolic blood pressure. Again, you have to be able to measure these things, so you need a little bit more sophisticated monitoring than in the triage sieve. And then it scores you as a T1, T2, and T3. And that really just is the priority of treatment. But it's the priority of treatment if you've got lots of casualties. If you've only got one casualty, then it doesn't matter because that patient just gets treated. If you've got capacity to treat 4 and you've got 4 T2s, they all get treated at the same time. It only really becomes a feature when you're overwhelming your local infrastructure, and then you need something that you can put in place. This is just kind of the latest iteration that shows you how you can argue about the sort of the respiratory rates and the sort of levels that it goes out and the level of heart rate, but they're all broadly similar. And the UK civilian emergency services use something that looks very much like this and looks very much like the military system. So I think that's probably, we can just stop showing those slides now because that's probably all we have to do for that. And I can't remember the initial question you asked that talked about triage, but hopefully that covered it.
Thank you. I think interesting comments in the chat. I think I'm just gonna read this out because it's quite important. In Ukraine, it says Russia bombs all buildings, infrastructure, or vehicles with painted red crosses, especially in Mariupol. I think that's a follow-up to hide the hospitals in this type of war. I don't think I expect a comment on that. However, if we are going to make it even more practical, and I think you mentioned something just now, and again, try not to think, experienced personnel, trauma doctors, or pre-hospital doctors like we have here in the UK. Just think of all doctors, junior doctors that are just brought into this. So if you were to choose the most important skill or the most important piece of equipment that you have to carry or learn how to use, which would that be, the skill or equipment that you think could save the most number of patients, the highest number of patients?
Tourniquet.
Yeah,
I mean, that's absolutely unequivocal from the evidence we had in Afghanistan that early application of tourniquets, and they were very rarely done by anybody with medical training. They were done by buddies, soldiers, basically, and the guys on the ground often would go on patrol wearing tourniquets. So all your buddy had to do in the event of you being injured was basically come and tighten them up. given the fact that hemorrhage control was what uncontrollable hemorrhage was the biggest cause of preventable death. They definitely saved the most lives, and there's very clear data on that. Now, Afghanistan was a slightly unusual conflict in that the signature injury pattern was caused by one particular type of device, which was an improvised explosive device, which was a blast injury, and often against sort of dismounted personnel, so people who weren't in vehicles. It caused the signature injury of the Afghan campaign, which was bilateral lower limb amputation, often, triple amputation with upper limbs as well. And that's because of the particular blast pattern. But I think you can see that any conflict and any urban conflict, when you have, large amounts of, high explosive munitions being thrown around, produces blast injury. It's unlikely that it would produce, you wouldn't expect in the conflict that's going on at the moment to get broadly that same injury pattern. But I can't see any reason why hemorrhage control would not still be the #1 priority. If you look at the total, there's preventable and non-preventable death, and non-preventable death tends to be central nervous system catastrophic brain injury, essentially. And there's not, there's very little you can do about that often with any kind of medical infrastructure. But hemorrhage, you can do stuff about. There's also, so tourniquets are cheap and you can improvise. You don't need a sophisticated cat tourniquet. You can just put anything on that's going to produce the required response. There are other agents that you can use that are available, which are hemostatic devices in the form of bandages that were often really useful when you had extremity trauma, but in junctional regions. So groins particularly, where you couldn't get a tourniquet above the injury, and you would put a HemCon bandage with a pro-hemostatic agent and packed it into the wound. Those are certainly readily available in Western militaries. I suspect they are much more available than they were 10, 15 years ago, more broadly internationally as well. And as I say, you don't need any kind of experience or expertise to do this stuff.
Thank you so much, Sam. Currently, there are no new questions. I would like to go back to the triage, because I think that's a crucial thing. One could imagine that colleagues would have to triage, or even soldiers would have to triage on the combat line, so that when casualties move up the chain of transport, that the first triage is done in the combat zone, or even in a civilian setting, if there's a city that gets attacked or bombarded, and then the hospital is too far away, or the care facility is too far away, so that they would have to do the triage on site. Whereas you could also imagine that the hospital is over, you have an influx, really mass casualty situation at a care facility or hospital. Do you think that it's possible to quickly, and you mentioned that the triage was often not performed by physicians or not highly trained clinicians. Do you think it's feasible to train non-clinicians or even not health professionals to perform the triage, to use the resource of a clinician or healthcare provider and not put them either harm's way or to put them into clinical care? Do you think it's feasible to train non-health professionals to perform triage?
Yeah, yes and no. I mean, there's sort of up and down sides to it that you've alluded to. I mean, but often you want reasonably experienced people doing that, because it's one of the more important jobs, isn't it? It's one of the more important things to prioritize. Trying to pick what you're essentially trying to do. You've got three broad groups when you're triaging. You've got the people that will die, the people that will survive, and the people in the middle. And it's the people in the middle that you want to invest your limited medical infrastructure on, because the people who are going to survive are going to survive. You can treat them later. The people who are going to die in this situation, they're going to die. You've got to do the most good for those other third. And the more experience you have, the more senior you are as a clinical decision maker, I think, you know, all of us on this group will know that, you know, it's incredibly difficult to look and detect patients who are, you know, critically ill and at risk of deterioration. It's something that's not done fantastically well often in hospitals. And it comes with experience. It's very, very difficult to teach, and often it's a feature of seniority to be able to do that. So yes, you might say, oh, I want to preserve my really senior people for doing the, you know, the jobs where they need to be operating, and that's true. But this is incredibly important to actually have people making the right decisions at the right point. So it's a yes and no is the answer to that, really.
So thank you. I think you know that, but I do find triage to be a very difficult notion, and I think that is probably, as I listen to you now, probably just a symptom of how privileged a life as a doctor I probably have and have had, and probably many people as well. And I know we drew many analogies between the pandemic and the war. I am not sure that now that some people are actually experiencing a war, and we are experiencing a war really close to us, whether that analogy was actually right or very true or not. But I do wonder whether there is something to be said about entering a war situation and knowing that at some point you need to make difficult decisions, and that somehow, I don't want to say it's okay because it's never okay, but somehow, because it is war, because resources are limited, somehow it happens. You just have to do it. Do you think that makes a difference in the decision-making process? Does that make it a little bit, I don't know, easier? Or is it still, I don't know.
Yeah, you and I have kind of talked about this as well. I mean, I think it comes down to, a lot of it comes down to personality type as well, and how easy and difficult. Well, I don't think anybody ever finds this easy. But, you know, there's this kind of, you know, pragmatic personality type, I guess, that enables you to sort of go into these situations and go, well, I'm going into crisis management mode. And I think there were clear parallels really with COVID. It's a similar situation in some ways, in that you have an overwhelming of your normal medical infrastructure by a catastrophic, unpredictable situation that comes out of the blue. And you have to be in a decision to try and do the most good for the most people with the limited resources that you have. I think people in the military they sort of have a leadership and command structure that I guess enables you to kind of accept those things a little bit more easily than maybe people who haven't encountered them. And that is important, I think. You know, there will be situations when we were deployed when, you know, the priorities of the commander running operations wouldn't trump any medical decision making, but, you know, you may have put yourself in this. Ultimately, the field hospital is certainly in the NATO military situation, is a tool that the military uses to achieve its objective, and it needs those beds and that treatment infrastructure to make sure it can treat wounded casualties, because if it can't do that, commanders, certainly in a Western military context, can't embark on operations now unless they have the capacity to provide that level of medical support to their soldiers. And so that kind of does trump everything. If you're serving in the military, you have to kind of fit into that framework.
Tobias, do you want to get the next question, or shall I?
Yes, I'm actually currently reading the next question. I'm trying to get it right. So one of the participants asks, how can you, what you just mentioned, Sam, actually, is how can you change the mindset of your clinicians within your hospital? How can you in particular change the mindset of a general surgeon that's used to perform elective surgery, and now he has to perform damage control surgery all of a sudden? So how can you quickly prepare clinicians, or in particular surgeons, that they have to change their mindset and their patterns?
I've just read that question. That's a really good question, and quite depressing as well, because for somebody who's been doing damage control, resuscitation and surgery for a long time now, I thought we'd kind of done that. I thought that was an established thing that was true. Obviously I work in an ivory tower where it's not true everywhere. Now the key thing there for us was pre-training and team building, which isn't going to be the case if you're suddenly dropped into the middle of this question is about a terrorist incident in a civilian setting. But we did an awful lot of pre-deployment training where we try to overcome the kind of institutional problems with anesthesia surgical interface. Whereas the surgeon wanted to do the procedure and fix the anatomy, but the anaesthetist wanted to, could see that the physiology was profoundly deranged and the patient was, wasn't the right thing to do for the patient. And we did it using just a lot of, pre-deployment sim training. We had one thing that worked quite well. And I was actually flicking through some stuff that I'd looked at this before. So we had things we used to do before an operation. So a damage control, resuscitation, surgical operation, we would have something called a command huddle, where you would have usually the deployed medical director, both surgeons, or sometimes three surgeons if there's a plastic surgeon there as well, anaesthetist, intensivist. And you would kind of decide up front what your priorities were for that procedure. So there was a plan, and they would go, right, we're going to tackle this in this order. So we're going to open the abdomen, we're going to cross-count the aorta, we're going to get proximal control, and the general surgeon's going to do that. And at the same time, the orthopedic surgeon's going to do, bilateral lower limb amputations. The plastic surgeon's going to do, going to work on the upper limb. Where the massive transfusion bit was so set in stone by this stage that it kind of just happened almost in the background, amazingly. And then you'd stop throughout the operation, and you'd have, we used to call them snap briefs. You would actually sort of do it almost like a timeout, like you do at the beginning of an operation now with a kind of WHO checklist. But you could stop the operation and say, hang on, right, stop. I've got this rotem here. It looks awful. I've got this gas here. The lactate looks awful. Things are going in the wrong direction. We either need to stop completely, stop for a bit while we get on top of the blood product resuscitation. It's all about communication. I mean, almost everything in medicine, ultimately, I guess, comes down to teamwork and communication. And when you've got, high pressure situations like this, it's even more important. And often in these situations, we were lucky, we knew each other. We all worked together as a team, and we deployed together, and we trained together before we went. The situation of, that people may find themselves in other situations where they're all just dropped into it and they don't know any members of the team, makes it even more important. You've got to stop at the beginning and say, I'm this person and I can do this, and this is going to be my focus during this period of treatment. You're going to do this, you're going to do this, and everybody needs to be able to go, right, stop. This isn't going well. We need to rebrief and see what we're doing here. So it is very difficult, but incredibly important. And we didn't do big anatomical reconstruction generally in the first operation in the settings that I worked in. It was do the minimum you can, resuscitate, get out, come back the next day.
Thanks, Sam. I do hear this repeated by you quite a lot now in different forms. So it's interesting that results are better in settings that have done this before and do the same thing, just one thing, which is, trauma and trauma management. We've seen this outside of, war situations, high volume centers, better results than others. And then again, results are better, maybe morale is better in teams that, every role is allocated, everybody knows what they're doing, in teams that know each other. It seems to me that this is something that maybe we do know, all of us in our civilian lives. It seems to also apply in other war situations. But I do wonder, and I think just this is another way of asking the question that's been asked before. I am not sure how we can preempt for that if something catastrophic just falls on you, if just some a terrorist attack, a war out of a sudden. Does that mean that, do you think that should be part of everybody's training because now things are like that? Do you think if these things happen, then people with experience should just take over and tell everybody or organize people that don't have experience? I'm just trying to find out.
Yeah, I think clinical leadership is a skill that can be taught. And it's like the military would say that, nobody's a born leader. Everybody has potential to lead, but you can train to it. And the reason that people in the military are kind of maybe more comfortable doing that is because they're probably self-selecting, and that's why they go into those roles in the first place. But maybe we don't place quite as much. Our leadership structures in civilian healthcare are pretty horizontal, aren't they? Generally, they're not like that, which is kind of like a more military model, and that's appropriate. I'm not saying that should change. But in a situation where you're operating in extremis and you do need to have a more vertical structure of command and leadership, I think you can train anybody for that, but we maybe don't do that quite enough because the way our normal working lives play out, that's often inimical to good outcomes. Having somebody at the top saying you've got to do this and being very didactic doesn't work. But sometimes you kind of do need that. And I think what I do often when situations in clinical practice are very fraught is if you can try and do this kind of stop, pause, and almost like do a very quick brief. And I think you see a lot of quite effective people do this. Brief the situation, allocate roles, everybody knows what they're doing. And often in the kind of bedlam of a lot of bad stuff happening, it's difficult to actually do a distinct pause and take the time to do that. But I think it's very, very important, and it's something that anybody can do.
I totally agree with Sam. It's a very useful tool, and I will cite you if you may allow. There's one question on the aspect of de-skilling trauma units. If all the patients go through these trauma centers, and that leading to de-skilling of trauma units, that's definitely an issue, how to keep the balance between the competence level in terms of volume between trauma centers and trauma units. This refers more to a really civilian setting. But I would like to go back to the infrastructure necessary to set the multi-level care system up. How can you manage? I can imagine it's really difficult to provide all the resources that you require for the different care levels in terms of blood products, fluids, oxygen. How can you maintain the logistics of the system you described at the start of our session?
Yeah, it's anybody in the broader military outside the medical world will tell you that operations will fail or succeed on the basis of the logistic support. And I think you can see that happening, playing out on the news actually, in the current situation in Ukraine. Again, we were very lucky in that the stuff I did when I was deployed was pretty well established, and we had very good dedicated supply chains to get us all the stuff that we needed. And I don't know that there's an easy answer to that. If you can quite rapidly run out of stuff though. I mean, I'm Navy, as I said at the beginning, and although I seem to have spent most of my deployed experience working in land-based roles, it's very, very important when you're in a maritime setting, because resupply is more difficult to get stuff out to a ship, to work out, what you need and how quickly you're going to use it. And I remember when I went to Sierra Leone on our hospital ship, the first thing I did was sit down and go through all of the main consumables that you would run out of in an intensive care unit are basically propofol and opioids. So, and we actually didn't have that much. So you've got to know how much you've got and how quickly you're going to go through it. And like we saw in COVID, you can use other stuff. There's usually other stuff that will achieve the same effect, maybe not quite as well. But there are usually other things that you can scrape together that will achieve the same stuff. I think blood products is a very difficult situation, and often in a combat military casualty situation, in a very remote, low deployed hospital care environment, you either don't have blood products at all, or you have a very limited supply. And that's where you run into the situation where you have to consider the use of fresh whole blood, and that's not an area that's not where my academic interests lie. But that is a very large area of work in the UK and US military, of trying to work out how you can get blood far forward, and how you can deliver either fresh whole blood or various modifications of component blood therapy to far forward areas. I mean, you can use, ultimately it falls back on, you've got very small groups, particularly far forward military operations with small teams. They will have to use emergency donor panels, so they will rely on blood donations from other members of the team. But to do that safely really needs pre-screening. So these guys will be pre-screened with laboratory tests for infections and things before they go. And you're not going to be in the luxury of having that if you've suddenly got a major incident hitting your country. But that may be what you have to do. At the end of the day, you can go through, and there's been little bits of work done on screening questionnaires to try and rule out people who are at higher risk of passing on infectious diseases from the use of unselected blood transfusions. But there's still an element of risk to it. But sometimes that is a risk-benefit equation.
Right. Thank you. I don't think there are any other questions on the chat. And I wonder whether I can start summarizing. I think what and by all means, correct me if I'm wrong, what I heard, Sam, and I think you were very clear from the start that the view you're presenting is the view of a more organized, preset, ready to go approach, and is not the, a civilian setting that some horribleness just was dumped on it. But what I heard, and in order to summarize, is I think you were, hold on, yes. So the fact that approaching traumatic war injuries definitely needs some organization and some tiered approach, also from where to, initial management at the field, and then a second tier, and then the full ICU, fully knowing that you might be lacking the all singing, all dancing trauma ICU unit, or that we never may have had it, or it might have been destroyed. So a tiered approach, doing everything that you can with who you have in each tier. You talked to us about transport and how important it is to have a robust transfer service, or to create one with whatever means you have at your disposal. And that sometimes if you do have a transport system, a transfer system that is that's really robust, you might not even need middle hospitals. You can, of course, depending on the distance as well. You had some lovely slides, and I'm sure they're going to be freely, available to all after this, about the triage sieve and how to guide you to make these triage decisions, and that, of course, experience is very, very important. But even if you don't have experience, there are some tools that even, lay people may use to help go through patients, especially when the number is sometimes kind of crippling. Practically, you told us that if there's one thing to take away or to use, would be a tourniquet, mainly because the highest number of deaths in traumatic war situations will be from hemorrhage. And that, I'm sure you don't have to have high medical experience to use that. And I wonder whether, as a last thing to take away, is that sometimes, especially as we've heard in the comments, you don't really have an organized unit, or your hospital has been destroyed, or you've run out of equipment, or you've run out of drugs. I think you can do what you can do with the things that you have, and just accept that this is the horrible nature of war, I guess. I think that would be my summary. Do you think, Sam, Tobias, do you think that's reasonable enough?
I think I have the same takeaway from Sam has told us. There's just another question in the coming up. It touches down on things that we've already discussed, is how to, and that you already mentioned this, you mentioned the importance of command and control, and that is how to transform actually a civilian hospital from scratch. The colleague talks about terrorist attacks in Paris and Barcelona, but it's, the colleagues in Ukraine, they're not really in the same situation anymore, because they are right in the war now for 5 weeks. But you mentioned already the principles of command and control, and that some verticality is necessary to impose a certain structure. But at the same time, if I understand you correctly, to keep a level of subsidiarity at each level of care. But I totally agree with you, Victoria, on your take-home messages. We have still some time to go. I think it's important to mention, as you said, Sam, that the content of the webinar is not. These are the lessons. You should do this way, and this is the NATO or the UK way to do. Is offering some pearls of wisdom, of experience, that colleagues in Ukraine or in the neighboring countries can use then to think about how they can make the best use of their available resource. Do you agree, Sam? It's not about telling.
Yeah,
one way.
No, absolutely not. And it's a situation which I've never been in, and hopefully never will be in, and that I've always worked within a discipline structure that was very well resourced and equipped, even if it wasn't in an area that was generally resourced and equipped. And that's a totally different situation to the situation that that people in this war zone now will find themselves in. And unfortunately, there's no one size fits all answer to any of these things, and there's no easy solutions to any of these things. The thing I think you can apply anywhere is having some structure, and having, it's all about what gets you through any of these really difficult situations, is having a usually what gets the military through, what gets me through, some of these difficult deployments is having a small team that works and that supports each other. And that's essentially why people in the military fight. They don't usually fight for some, high strategic ideal. They keep fighting because the person next to them keeps fighting, and the whole team brings each other on. And I think that's true in a medical sense. It was true for COVID. I think that's how a lot of us, got through the COVID situation. It all comes down to small unit leadership and being prepared to, go through things that everybody else is going through and share the same risks. And that's always been the way. That's always will be the way in these very difficult situations. It doesn't need high-tech solutions, but it maybe is the most important aspect, the small unit leadership and camaraderie at the end of the day.
Yeah, I think that does echo very, very true. Tobias, you did read that last comment, I'm sure, but I think that's also very good. That's a very good protocol. So the colleague does say that in Paris and Barcelona, after the attacks, all hospitals have to have a protocol to basically be able to respond to mass casualties and reconvert a hospital into a trauma center. So I'm not sure we have it here, Sam. I know we did weird, wonderful things for the COVID pandemic, but I do wonder whether that is something that people in non-war civilian countries can take, that kind of anticipation. It seems like things happen in life nowadays.
I think most hospitals, well, all hospitals have a major incident plan, don't they? But usually the first time anybody sees the major incident plan is after the major incident.
Yes, that is true. That is true.
It's not something that anybody generally is terribly familiar with until they realise they need to be, which I think is just, it's a fact of life, isn't it?
There's the WHO has currently running a sort of program where they chose some candidate hospitals in different countries to teach them a method, and then as a snowball effect, they can teach other hospitals and other teams to how to focus on the first hour and how you can get this transformation done within an hour and what you have to focus on. So that to transform your hospital, and it's a lot based also on the experience of colleagues from Israel, colleagues from the Royal London. There's a tremendous work is done by Rosa Tallack. I don't know whether you've seen the special issue in the British Journal from January. So for colleagues who would like to go into these to find a method how to do this and how to transform. I can really recommend the special issue from the British Journal from January. A lot of great papers in there with really very precise and concise how to do this papers. And I would like to ask one question, even if it's going back to our beginning of our sessions. You mentioned the MERT experience and the forward deployed medical team providing very advanced care, and that this allows actually to jump, if I understood you correctly, to jump levels in the tier level, to jump, for example, from forward deployed to even to a 3-tier level, which is probably more in the safe zone. Do you think this could be a feasible strategy in Ukraine, provided they have, of course, the medical resources or the human resource and the competence, and also the transport resource, so they could bring people out of the combat zone into more protected areas where they can get hospital care?
Yeah, I mean, indeed, but it's and it doesn't have to be as sophisticated as what we were providing in Afghanistan. I mean, throughout most of the history of medical evacuation, we kind of, Afghanistan and that conflict was really the pinnacle of what we were providing. But if you look at what was provided, in Korea and Vietnam, it wasn't, it was paramedical evacuation, but it was often, on a stretcher on the outside of an aircraft, you just need to go fast somewhere. There's different tiers of response. It's always better to be somewhere where you've got a surgeon, you've got a means of hemorrhage control, and you've got a means of providing massive transfusion, and you've got all of the other stuff. How you get there is less relevant than getting there as quickly as possible. And what you wouldn't want to do is hang around and go, we can't do this because we need this sophisticated system with a Chinook helicopter and a 5-man crew and a physician, and we only evolved into that during that conflict. We didn't deploy at the beginning with that capability. We have that capability now, and can deploy that now for future conflicts. But that evolved out of the conflict from something that was less sophisticated. And even not all NATO countries have that model. So a lot of them, not a lot of them, but some of them still have this kind of rapid scoop and run strategy.
Sam, there is another question, I think, in the chat concerning C2 theatre. Medical regulation is very important when transmissions are working. I think that's more of a statement, I guess.
C2 as in what? Hang on, command and control. Yeah, I mean, I don't know exactly what that question means. There was always a lot of problems with bandwidth and transmission during conflict, even if you've got a pretty sophisticated setup. And it would be one of the ways that you can kind of get around the sophistication gap in a conflict zone is with telemedicine. And the military have been sort of exploring this for quite a long time. But I guess from a personal view, often the problem is you're competing for bandwidth, communication bandwidth, with a lot of other stuff that the military is trying to do. And you need a lot of bandwidth to do proper telemedicine, because you need a lot of sort of high-end, video links. So to my knowledge, I certainly never encountered it in any of my deployed experience, but I know it's something that's sort of been on the priority list for quite a long time. Because, for example, in the UK military, we don't actually have that many intensivists. And we're not in a position of deploying intensivists to a lot of these particularly smaller medical treatment facilities. But you can imagine if you had, a very sophisticated, secure network with unrestricted bandwidth, so you specialists who are maybe anaesthetists or others could show patients and show imaging and talk through stuff with an intensive care specialist who was remote, that would be advantageous. But I don't think, to my knowledge, we were in a position even in the military where we've managed to achieve that yet.
Understood. Thank you. I think there are other comments in the chat. Again, from a colleague who, like myself, never been in this situation before, the very first action should be reviewing all available resources, staff and space, I guess, and communication, and try to match them to the demand as quick as efficient as possible. Yeah,
I mean that's definitely true. And there's a whole career of people in the military who do that. Who are non-clinicians, but within the medical organisations of their own militaries, who are basically staff officers who try and do exactly that. It's quite a difficult job, because you do something called the casualty estimate, and so you look at previous conflicts and you go, based on previous conflicts, what kind of medical resource do we think that we are going to need for this thing that we're embarking on in this circumstance? And it's quite challenging to get the numbers right. Either if you undercook it, you end up deploying more valuable medical resource than you need, who then sit around not doing very much. And if you go the other way, you run out of medical infrastructure, and it's so dependent on events. And each conflict is unique, really, in terms of this. And also the population that you're treating is very variable from a military point of view. You often go into conflicts going, well, we're only going to treat entitled UK, US, NATO soldiers. and invariably that becomes blurred, because you end up, people get involved, people get injured, they get scooped up by our medical retrieval services, and we end up treating them. And like I said before, in these enduring operations, a lot of the focus was on treating local nationals, certainly in intensive care. They were the bulk of the patients who were on the intensive care at any time were local civilians.
And I guess that is when you go expecting casualties, let alone if something just, happens to your country or to your hospital or to your region, I guess. And that's why I wonder whether the previous comment on having something ready to go, instead of trying to do all this assessment where everything is really hot and happening, would be maybe more beneficial. Tobias, should we slowly, I
think we should slowly come to a conclusion. I was just checking whether any other questions. I can't see any other questions. So I think you have really very nicely summed up the key take-home messages, Victoria. It's obvious that the logistics and resource management is key, as you just said, Sam. And when you look at how MSF, that is a civilian organization, Médecins Sans Frontières, but running in combat situations, providing care in combat situations, and in a very austere and hostile environment, I think the logistics function that you just mentioned is key to the success of the mission. So I think what you've just mentioned is the hand-in-hand work of clinicians, providing the ongoing information of what they need, anticipate need, and people that deal with the logistics, providing the resources, even if they're restrained, is a key to success, I would say. What do you think?
Yeah, undoubtedly. And it is something that other countries, can provide to, nations that are in a conflict zone. That they can help with that, that critical logistic component, because, it is always the thing that will bring down any system, running out of stuff, running out of resource.
So maybe we cannot, but it would be, there's actually a question coming up here.
More of a comment.
More of a comment is that the International Committee of the Red Cross and Médecins Sans Frontières, they actually provide mass casualty incident training in these areas.
Oh, that's good.
So that colleagues can in these countries can deal with this kind of situations. Also refer maybe to a question we had at the start of the webinar about conflict situations such as Burma that even have a lower resource. Maybe we should come to an end if there are no other questions.
Sure. Sure. Should we thank Dr. Hutchings? Sam, thank you very, very much.
Really, yes.
Thank you very, very much. Thank you very much. It was a very valuable insight. I hope everybody was able to take something out of it. I find this whole situation extremely humbling. We only touched, I fear, on only a little bit of it, isn't it? The trauma management, a little bit of triage. I think if we start thinking about all the other non-trauma related injuries that this country has to, or all other countries in this situation have to deal with, all the collateral human damage, I think this becomes almost unbearable. But thank you very, very much, Sam. And
yes, a pleasure. Thanks for the invitation.
And thank you all very much for participating. We do hope you found it very, very useful. Tobias, do you want to maybe speak a little bit about the next webinar of ESICM?
Yes, I would like to speak about the next webinar, but also would like first to thank Sam as well, because it's a very difficult exercise, and I think you did really did really great, and I think you said the key word. The key word is humble. I think we're all very humble, and I think it's obvious that we're all affected. So thank you so much. This was really, I learned a lot, and it was an excellent lesson in humility. Thank you so much, Sam. So the next webinar is on next Wednesday. It's at the same time, like all the webinars. It's at 5 in the afternoon at Central European time, on the 13th of April, and the topic will be hemorrhage management and shock management for war injuries, and in the context of combat medicine. So thank you so much. Thank you again, Sam. Thank you, Victoria. It was a pleasure to host this webinar with you, and we'll wish you, for colleagues in Ukraine, a safe evening, and for the others, a good evening. Okay.
Thank you all. Bye.
Thank you.